Thank you for all coming. It's a pleasure to present expert insights on new systemic therapies for advanced prostate cancer on behalf of my co-presenters, Dr. David Penson, Dr. Daniel Lin. It's my pleasure to open this program. I'm Dr. Daniel Petrolak. I'm from Yale University. So our faculty include, as I mentioned before, Dr. Lin, who's Chief of Urological Oncology at the University of Washington, and Dr. Penson, who's Professor and Chair of the Department of Urology at Vanderbilt. So this is our agenda. Dr. Penson is going to be starting off with advances in non-metastatic castrate-resistant prostate cancer and high-risk disease. Dr. Lin is going to be talking about the current recommendations for metastatic hormone-sensitive prostate cancer in 2019, and I'm going to be giving a talk on biomarkers in the treatment of advanced prostate cancer. Now let's get on to the meat of the matter. It's my pleasure to introduce my friend and colleague, Dr. David Penson, who's Professor and Chair of Urology at Vanderbilt University Medical Center from Nashville, Tennessee. Unfortunately, I guess he's got to root for the Predators. And he's going to be talking about advances in non-metastatic castration-resistant prostate cancer and high-risk disease. Dr. Penson.
Thanks, Dan. Thank you. Talk about bringing up a sore subject. So my hockey season is over. Thank you. Next year. It's always next year with this team. Anyways, thank you so much. It's nice to be here. I think I drew the easiest of the three jobs, talking about advances in non-metastatic castrate-resistant prostate cancer and in high-risk disease. I think it's easy because there's a fair amount of new evidence to review, a couple of phase 3 clinical trials. And I think we should start with a case. So here's a fairly common case I think we see in practice. A gentleman who 6 years ago had robotic prostatectomy and pelvic lymph node dissection. His baseline PSA was 18. When his prostate was taken out, his initial pathology was a Gleason 8. It was T3B N0 with negative margins. His PSA naters to undetectable levels, but then becomes detectable again 24 months after the operation. He has a bone scan at that point, which is negative. Given this, he gets salvage pelvic XRT and gets really almost no PSA response. So he opts for ADT at that point for suspected micrometastatic disease. He starts with intermittent ADT and then ultimately converts to continuous ADT, and he does have a good response until now. 4 months ago, the PSA is rising despite castrate levels of testosterone. The initial PSA 4 months ago was 0.4. It's 0.7 1 month ago, and now it's 0.9. So the doubling time is roughly 4 to 5 months. He has a repeat bone scan, which is negative, a negative chest and abdominal pelvic CT scan. In your current practice, which would you recommend? Continued observation, perform molecular imaging study, and then make a clinical decision. Add abiraterone, add apalutamide, add bicalutamide, add enzalutamide, add start please LT, start docetaxel, or I don't know, uncertain. Great. I see there's a lot of folks out there who are doing molecular imaging, and we will count on that, talk about that in a moment, but that's sort of where we're starting. Let's talk about evidence from recent phase 3 trials that I think guide you in this particular patient. This patient has M0-CRPC at this point, and in these patients there are now treatment options which are FDA approved. So when you're thinking about patients who have M0 disease, M0-CRPC, I think there are a couple of things to consider. First is PSA doubling time. And we're going to go through these studies, and I think a key point is that the doubling time makes a huge difference. And if you look at the NCCN guidelines, and I will show you that schematic, if your doubling time is more than 10 months, the recommendation is observation or other secondary hormonal therapies. If it's less than 10 months, however, either apalutamide or enzalutamide are indicated, although you could consider other secondary hormonal therapies. Now, a lot of you mentioned molecular imaging. I think this is a rapidly advancing area. We now are up to, I think it's radar 3, which Dan was involved in and I was involved in, recommending imaging. A lot of that, as you all know, is driven, unfortunately, by insurance companies, but there are PET CTs and PET MRs which are available that may play a role here. And they may make the patient an M1 patient, which changes the algorithm somewhat and actually increases the number of available options. Let's talk about the data backing up those two areas about doubling time specifically. It's fairly well known that a faster doubling time is linked to shorter time to METs in patients with M0-CRPC. These are numerous studies. You can see if your PSA doubling time is less than 3, your median time to METs is 9 months. 3 to 8.9, it's 19, and then it jumps up to 40 months if it's above 9, and 50 months if it's above 15. And basically, you can see right there on the right that the risk of bony METs is 10 times higher if you have a quick doubling time, and the risk of death from prostate cancer is 4 times higher. And I think this is a key point when we look at the trials in this space. The design was such that it really focused in on patients with really rapid doubling times, because those are the ones who need help, and of course those are going to make the trials happen quicker, frankly. Hopefully you can see this. This is the actual table from the NCCN guidelines around PET imaging. And I think it's worth talking about this a little bit. At this point, there's real excitement, I think, about fluciclovine, and some people would recommend that in this setting. About a third of the people in the room were suggesting that. I have some experience with C11 choline. I'm less impressed with that. And I have no experience personally with sodium fluoride. It's very regional, as you all know, depending on what your radiology colleagues and nuke med colleagues can get for you. There's real excitement about PSMA, but it's not widely available in the United States. I know in Australia and in some sites in Europe, it's very widely used, and I think the future is going to be PSMA scans. But there is a role here at this point, but it's evolving. This is a great slide that I think underscores this. This is a patient with M0-CRPC on a bone scan. You can see he had Gleason 9 disease, has a rising PSA, and the bone scans are basically negative. But when you get the PSMA scan, you can see that he does have spots beyond his liver, spleen, and intestines there. You can see how the PSMA really shows you lesions that you wouldn't have found otherwise. And this imaging is really very promising. But again, at this point, because it's not available in the U.S., it's got to be considered experimental. So let's assume the patient does get the imaging. Let's say it's negative, and the patient truly is M0-CRPC. Let's say you can't get the imaging, the patient's still M0-CRPC. What are your options? And there are really two important studies that you have to be aware of in this setting. And these studies were taken into account with the last NCCN revision of the guidelines, where I think we're up to version 2 for 2019 already, but this is already in version 1. This is the Spartan study comparing apalutamide, which I'll refer to as APA, versus placebo in non-metastatic CRPC. And you can see the study design here, and it's worth just noting the inclusion criteria. And there are some slight differences between the two studies. Spartan allowed patients who had pelvic lymph nodes, but did have a inclusion criteria. You had to have a doubling time of 10 months or less. But this business with lymph nodes is important because it makes a different study population than the next study. And you can see that the patients are randomized either to APA versus placebo. The primary endpoint is metastatic-free survival. You can see the secondary endpoints as well. We'll review some of them and some of the exploratory endpoints. The other study is enzalutamide versus placebo. I'll refer to enzalutamide as ENZA in non-metastatic CRPC. This is the PROSPER study, and I want you to notice here that these patients could not have nodal disease. So this is true M0 non-metastatic CRPC with a PSA doubling time of less than 10 months. Beyond that, this study design is fairly similar. The primary endpoint, again, is metastatic-free survival. Some folks have concerns about using MFS as the primary endpoint in this setting. The FDA did not have a concern about this. The FDA felt that this was a reasonable endpoint based on the ICE-CAP data, and I think that with time and follow-up, it'll turn out to be a reasonable proxy endpoint. Remember that ICE-CAP really looked at men with localized disease as opposed to presumed metastatic disease. Let's take a look at the patient characteristics, because as I show you these slides, you're going to see the results from both studies on the same slide. I don't want you to make the mistake of comparing them. These are not head-to-head trials, and so you can't look in one and say, well, the efficacy of this is better than the efficacy of that, because the study populations are slightly different. You can see here in PROSPER, the doubling time is just a little shorter than in Spartan, and I think that makes a big difference, and that may be related to that inclusion criteria around nodes. But you can see the proportion of patients greater than 6 months versus less than 6 months doubling time, the use of bone-targeted agents, and obviously those who had nodes and those who didn't. And roughly 16% of the patients in Spartan had nodes. Beyond that, they're fairly similar. And here are the key results slides. This is Spartan on the left and Prosper on the right. Spartan, again, is the APA study. Prosper is the ENZA study. In blue is the active agent. In orange is the placebo arm. You can see, looking at Spartan first, that you have a 70% reduction of distant progression or death. That's the metastatic free survival endpoint. And you can see that the median survival benefit is 24 months. It's 40 versus 16. And now compare that, or at least consider it, I should say, in relation to Prosper, which is ENZA versus placebo. And you can see there, again, you have a 71% reduction of distant progression or death. You can see that the median metastatic free survival benefit is 22 months, and it's 36 versus 14 months. And again, these are baseline differences in the populations that are resulting in differences in metastatic free survival. So you really can't compare them directly, but it's clear that both drugs are active in improving metastatic free survival. Secondary endpoint is overall survival, and we simply don't have long enough follow-up to make comments on this. You can see Spartan here on the left, blue and orange. Blue is the active arm, orange is the placebo. And you can see that the curves are starting to separate, but I think we're going to need more follow-up before we see a difference in this endpoint. Similarly, in the Prosper, you can see the curves are starting to separate, but again, they are not statistically significant at this time. So I think with further follow-up, we'll learn a great deal. This is time to PSA progression, and clearly both agents are very effective in prolonging time to PSA progression. On the left, you see Spartan. Again, that's the same color combination. And you can see in the treatment arm, APA, they haven't even reached the median median PSA progression point. And when you look at Prosper, they have reached it, and you can see that it's also quite effective on the right. The hazard ratio in both cases is 0.6 or 0.7. You can see the 93% risk reduction in PSA progression, and you can see the median time to progression is 3.9 months versus 37 months. So really highly effective drugs in both cases. Now, one of the questions here is, does these drugs have an effect on quality of life, be that positive or negative? And you can see in both studies that there are no statistically significant differences between the curves. On the left, again, is Spartan, and the right is Prosper, and certainly the curves are almost identical, and I don't think that what you're seeing on the left is meaningful. Those confidence intervals are wide, and they clearly overlap. So I think we can conclude that these drugs do not affect quality of life in a positive or negative way. And really, I would be more concerned if they were affecting it in a negative way because of side effects. So in this regard, I think they are well-tolerated drugs. Now, this is, I think, a very important slide. And for those of you who are at GU ASCO, I think it's now 2 GU ASCOs ago, the year before this past year, you may have seen these presentations when the data were released, and you can see the difference in adverse events. I'm going to turn your attention here to adverse events greater than grade 3. You can see 45 versus 34% in Spartan, 31 versus 23% in Prosper. The key finding that I think has to be acknowledged is that if you look in the Prosper arm, there were more major CV events, 5 versus 3%, and events leading to death, 3 versus 1%. And this was a big deal when it was presented in San Francisco. And I'm not going to make, I don't want to say excuses, because I'm not going to try to explain these data except to say that we have a lot of experience with enzalutamide in the M1 CRPC space. And if you look in the M1 studies, we didn't see this. So it doesn't exactly make a whole lot of sense to me that we found this here, but that being said, you can't deny that these are real numbers. And so I think that's something we can certainly discuss in the question and answer period. I'm curious to hear what my colleagues think about that. In the end, when you look at these two studies, and again, I want to caution you against sort of comparing one versus the other, you can actually see the course of disease. You can see on the top line is Spartan, the metastatic-free survival advantage, the median advantage is 24.3 months. And you can see 16.2 versus 40 months. And now we're going to have follow-up looking at second and third line therapies. Very similar with enzalutamide, 21.9 months. And again, we're going to get follow-up for second and third line therapies here. Now, that sort of covers the two drugs which are FDA approved. Let's talk a little bit about darolutamide, which is a new drug. These were published already in the New England Journal of Medicine earlier this year by Karim Fazazi. This is the Aramis trial. Again, a very similar design to the other studies. PSA doubling time of less than 10, had to have a PSA greater than 2 to get into the study, and a reasonable performance status. And again, your primary endpoint is metastatic-free survival. And here you can see the patient characteristics. This study looks more like the Spartan trial than it looks like the Prosper trial as far as the baseline characteristics. You can see the median PSA doubling time is about 4 months. You can see the breakdown of the other pieces as well. You can see that they did allow patients with positive lymph nodes into this study. And again, it is about 15 to 20%, although it looks like there is some difference between the two arms. That being said, the results, again, are almost the same as the two other studies. If you look at darolutamide versus placebo, you end up seeing a 22-month survival advantage from metastatic-free survival. It is highly statistically significant with a hazard ratio of 0.41. So this is another agent that ultimately will be effective in this space. At this point, it's under FDA review, is my understanding. Other endpoints that they looked at, overall survival, they have not quite reached significance here yet. It's awfully close. It's just below 0.05, so I guess by all rights it has, but neither arm has reached median survival. The hazard ratio is 0.71, but this does make me think in the future that all these studies are going to be positive for overall survival. You see significant advantages for pain progression, time to first cited toxic therapy, time to symptomatic skeletal-related event, progression-free survival, PSA progression, et cetera, so forth. So clearly, this is another effective drug that is coming into this space. The adverse event profile is favorable, similar to the other agents. If you look at grade 3-4, it's 15.8 versus 12.6. And I just want to point out that in this study, again, they are seeing a somewhat higher incidence of coronary artery disease, 1.7 versus 0.4. I don't know what to make of that because we have not seen that in M1 patients, but perhaps the M1 patients are, frankly, have a shorter survival, so they don't have the time on drug. It remains to be seen. I think this is a fertile area of interest of research going forward. So this is what the NCCN guidelines look like for M0CRPC. A key point, if you are going to follow the NCCN guidelines, and I hope you do, is that they recommend stratifying patients by doubling time. And if the PSA doubling time is greater than 10 months, they don't recommend these agents. The panel recommends either observation or other secondary hormonal therapy like, say, bicalutamide. However, if the PSA doubling time is less than 10 months, they recommend apalutamide or enzalutamide. And you can see what happens after that as they go on to progress on these drugs in PSA progression. So that is what the NCCN recommends. Okay, so let's change things a little bit and let's talk about biomarkers in high-risk disease. And this is a little bit different than what Dan's going to talk about when he talks about biomarkers in castrate-resistant disease in a different space. Let me run a case by you and see what you all think. This is a 55-year-old male with newly diagnosed Gleason 3+3=6 prostate cancer. He's got 1 out of 12 cores involved with 15% of this involvement, 3+3=6 disease. His PSA is 4.3. His DRE is clinical T1C. He's had a multi-parametric MRI, which shows no high-risk lesions. He's otherwise healthy with good erectile function and good urinary function. And here are your options. You could put him right onto active surveillance. You could order a bone scan and a CT scan. You get brachytherapy. You could do genomic testing in this gentleman. You can external beam radiotherapy, radical prostatectomy, or I don't know. So this is a good response of what I would have expected it, although I have to say there are a couple things here that I wonder about. Bone scan and a CT scan in a low-risk patient is actually probably not high-quality care. If you remember, there was a Medicare quality metric. that was aimed at reducing overuse of imaging in men with prostate cancer, and in men with low-risk disease, bone scan and CT scan are not indicated according to the guidelines. We'll talk a little bit about genomic testing in a moment. And I don't think brachytherapy, external beam, or radical prostatectomy are necessarily wrong if that's what the patient wants. But this is a patient with very low-risk disease. If we look at the very low-risk prostate cancer, a very low-risk group of the NCCN guidelines, in men who have a greater than 20-year life expectancy, you can see it says that active surveillance is really the preferred option. And I think that it really is the preferred option. Certainly if your patient is only a 10 to 20-year life expectancy, it's the only option according to NCCN. But if they have a long life expectancy, certainly surgery or radiotherapy is not wrong. Now what you don't see here is you don't see much about genomic testing. And for the most part, these NCCN guidelines recommend, they remain silent on the role of genomic testing in men with very low-risk disease. And that's inherently different than men with low-risk disease, where it is certainly something that is suggested we should consider it. And I want you to just take a look at this slide here. Let me see if I can get this to work. Here we go. So this patient has very low-risk disease, and they talk about germline testing, which is genetic testing, which is different than genomic testing. But when you're talking about genomic testing, which is molecular or biomarker analysis of the tumor, in men with very low-risk disease, it's not indicated according to the NCCN guidelines. I can tell you in my practice, I don't bother with it in these men. Frankly, I don't often get genomic testing in men with low-risk disease, for that matter either, but it certainly is something you can consider if the patient has a longer life expectancy. The patient I will talk to with genomic testing are patients with high-volume Gleason 6 and patients 3+or=7 disease, if they are trying to decide between active surveillance or an aggressive therapy. And often I think that gives them additional information to make them more comfortable with active surveillance or make them more comfortable with choosing aggressive therapies. So I think that's an important teaching point here in men with very low-risk disease. NCCN guidelines state that molecular and biomarker analysis of the tumor is not indicated. Now, let's talk a little bit about the available tissue tests and what's helpful and what isn't. We're going to talk a little bit more about Decipher. It's been studied in a number of areas. It's a good test, particularly in the post-radical prostatectomy setting when you're trying to decide whether or not to give adjuvant radiotherapy. And you can see what the NCCN puts out that basically cover post-biopsy for NCCN very low and low-risk patients. Other possible options include the Oncotype DX test, which you can see over here, and the Prolaris test. The ProMark is also available. I have no experience with ProMark. I do have experience with Oncotype DX and Prolaris, and in the setting of a patient with high volume Gleason 6 disease or 3+or=7, those are the tests which I often consider. But I want to talk to you specifically about a patient who has high-risk disease where I think genomic testing can be very helpful. And that's a gentleman who's had a radical prostatectomy. Let me run this case by you. This is a 58-year-old man who's had surgery. His preoperative imaging was negative. His preoperative PSA was 12.4, negative DRE. His final pathology is Gleason 4+=7, T3A N0, and he has a positive posterolateral margin at a site of extracapsular extension. His PSA, however, is nadir to undetectable levels, and he is now continent about 2 months after the operation. So my question is this: what would you guys do? Would you consider observation and early salvage pelvic radiotherapy, an ultrasensitive PSA, an Oncotype DX, a Decipher, or a Prolaris test? Would you give adjuvant pelvic radiotherapy, or I don't know? Oh, great. So a lot of people in the room would go with observation early salvage pelvic radiotherapy, and I think that is a very reasonable answer. In my clinical practice, that is usually my default position, although I will say up front, there are a number of level 1 large trials that argue that adjuvant radiotherapy is the preferred treatment in this particular patient. Whole separate talk, don't have the time to give it, but feel strongly about that. A number of people have talked about different genomic tests, Oncotype DX, Decipher, and Prolaris specifically, and people are mentioning ultrasensitive PSA. There is good data to support the ultrasensitive PSA in this setting, and there's good data to support Decipher in this setting, less data to support Oncotype DX and Prolaris here. Let's talk about those particular tests. Ultrasensitive PSA immediately after surgery in men with extracapsular extension and positive margin. This is probably the definitive study on this topic. 247 men status post-radical prostatectomy at high risk for recurrence treated at UCLA from 1991 to 2013 with a median follow-up of 44 months. If you look at the multivariable analysis of factors associated with biochemical recurrence, you see that one of the strongest factors, actually your ultrasensitive PSA. That if your ultrasensitive PSA is below 0.03 versus above, the hazard ratio for recurrence is 8.5, and that is highly statistically significant. More significant, in fact, than the Gleason score or the stage, although both are significant, but the hazard ratio is greater there. And when you look at regular PSA versus ultrasensitive PSA sensitivity and specificity, the ultrasensitive PSA definitely has better test characteristics, as you see on the right. Now, that being said, I still, wrestle with this a little bit, and I don't use much ultrasensitive PSA, but I have started using the Decipher in my practice. I think this test is very interesting. It's still somewhat early, but I think the data here are rarely convincing. This is a meta-analysis of 5 studies assessing the prognostic value of the Decipher test in this particular setting. So here you can see the treatment modalities, patients who had prostatectomy alone, adjuvant radiotherapy, salvage radiotherapy, or adjuvant hormones or salvage hormones. And you can see the follow-up is pretty long. It's anywhere from 7 to 9 years in these studies. And the goal here is to say, okay, fine, which of these patients after surgery are going to have a recurrence? And here you can see the cumulative incidence of metastases over time in this meta-analysis. And what you see here is in patients who are determined to have high-risk disease by Decipher, you can distinguish between those that are more likely versus less likely to have metastases. So this test is actually fairly useful for identifying patients at greatest risk for metastases. And so by extension, you would seem to think that these are the patients that might benefit from adjuvant radiotherapy. And if you do a multivariable analysis, this certainly holds up. We control for the other factors. This is still, Decipher is still a strong predictor of metastatic-free survival. Now, before you start getting Decipher tests on every one of your patients in this setting, I want to put a word of caution out there. And that is that this study from Dan Spratt, they're heterogeneous cohorts, and many received multiple treatments, and it's not always apples and oranges. Second, it's not always clear how much the genomic testing adds to the existing clinical variables. The multivariable analysis does a nice job of that, but in the end, these tests may not add that much more, just to simple stuff like Gleason score, PSA, preoperative PSA velocity, et cetera, so forth. And then to me, this is the key point, is that just because we can identify these patients at risk for metastases, it doesn't necessarily mean that we're going to change their outcome. Todd Morgan in Michigan is doing a study in this space, and I'm optimistic that these things will be useful for us, but we need to study them in a well-designed comparative trials, and Todd's is at the forefront of this. I believe that's my last slide. It is. I'll now take time to introduce my friend, Dan Lin. Dan Petrolak mentioned him before. Dan is professor and chief of urologic oncology at the University of Washington and at the Fred Hutch Cancer Center, and is really one of the thought leaders in the field. Dan?
Thanks. Thanks, Dave, and good morning, and thank you to the organizers. Okay, so my job is to, in the next 20, 25 minutes, talk to you about metastatic hormone-sensitive prostate cancer, and I think it's safe to say that this field has gotten crowded and will be getting even more crowded over the next few years as more trials are developed. And again, my job is to give you hopefully a few pearls, a couple, about how to treat these patients. These questions will be coming up on your recertification, and for the house staff in the room, certainly on your in-service exams, on how to treat a patient that walks into your clinic with newly diagnosed metastatic disease. So they're intact, have a normal testosterone, but they have metastatic disease. How do you treat those patients? And what are the treatment paradigms? What do you have to consider during the treatment? So we'll start with a case also, just like Dave did. This is a 61-year-old, again, newly diagnosed metastatic prostate cancer. He's an otherwise healthy man, comes in with some chronic back discomfort, was sent to a urologist because of some voiding dysfunction, found to have a PSA of 54. Had never had a PSA before. Digital rectal examination, globally integrated prostate, a biopsy confirmed high volume, high grade disease, multiple cores from both sides of the prostate. Staging studies showed some mild pelvic lymphadenopathy on one side and just some small sclerotic lesions in one spine at the L3, as well as in his right ischium, confirmed by bone scan. So, what would you do in your practice? Would you recommend ADT alone, ADT plus bicalutamide, ADT plus abiprednisone, ADT enzalutamide, ADT docetaxel, ADT plus RT, or uncertain? Okay, great. So the majority would give ADT Abi. Great. And then there are some others opting for other anti-androgens and even chemotherapy, but a large proportion gave either ADT or what we call complete blockade with the addition of first-generation anti-androgen bicalutamide. So here we go. This is the agenda. I'm going to review, again, very crowded space. It was just one or two trials originally, but now I'm going to review all the available clinical data, Latitude, Stampede, Charted, GETAG, and then ARCH, the newly ARCHES trial, and then do an overview of the NCCN guidelines. And again, this is where I hope that you'll walk away with just some practical guidelines of how to treat a patient like this in your clinic, and some issues surrounding the choice of therapy. And then the last is just to tell you what's on the future, which is the ongoing clinical trials in this space. So just to remind you again, this is a well-known slide from Howard Sherrill many years ago, but looking through the spectrum of prostate cancer from perhaps this is really the landmass of prostate cancer that you see in your clinic, the clinically localized disease. But what we're really talking about is here, someone that either walks in the door here or perhaps was treated and then has recurrence, and then now has metastatic disease, but again is non-castrate. So that's where we'll focus most of our attention. This was the Charter trial, came out several years ago, was updated more recently, but this really was the cornerstone of, hey, chemotherapy or other than just hormonal therapy alone works. And this was first reported by Chris Sweeney, of course, and this was the update when we looked at chemotherapy with ADT versus ADT alone, and then dividing it between high volume disease or greater than 3 metastatic sites or low volume disease. And you can see here that there's a clear advantage to the addition of chemotherapy early on. So someone walks right in your door, metastatic disease, adding chemotherapy alone should go through all of our minds now, particularly in what we call high volume disease. In low volume disease, it's really borne out that the addition of chemotherapy did not seem to benefit the patients over hormonal therapy alone. So again, this was the very first trial showing chemotherapy, and there now have been many others. This is the Stampede clinical trial design, and I'll remind you, just keep this in your mind because we'll refer to this later in the talk. This is a very novel design of a trial. You can see that it started with ADT alone in arm A, but then there are multiple different arms in which the patient have been tested, and they've had a plethora of publications and studies on this, and what I'm going to focus on right now is the chemotherapy arm of that is a companion to the Charter trial. And the bottom line is, just to cut to the chase, very similar results. This is the Stampede for overall survival. You can see here that this is standard of care. This is ADT plus docetaxel versus just ADT alone. You can see here a clear survival advantage of about 10 months with a hazard ratio of 0.76. And this is for all comers in that trial. And there were some M0s, but when you look specifically at the metastatic patients, so specifically at those that had M1 disease, and you look again at the median survival benefit was even more, and you look here, it's over 20 months, almost a 2-year survival advantage with simply the addition of docetaxel early on in the course of their therapy. There was a trial called the GETAG trial, and I just put this in here for balance. This was a trial that was run in France that was a very similar design, ADT plus docetaxel versus ADT alone, and you can see here it was not significant. And why was that? And there are many different reasons why. Partly there must be for volume of disease and other issues, but clearly there did not seem to be a difference. However, when the two principal investigators combined their data and showed the combined data, and here's the combined data, I'll just focus here on this side of the slide, the high volume disease, and it's kind of busy, but basically the dotted lines there are the docetaxel arms, and then here is almost superimposed the ADT alone arm in both the Charter trial and the GETAG trial, again showing that there's a clear advantage at a hazard ratio of 0.68 for the addition of docetaxel early. So the take-home message is ADT plus docetaxel works, high volume disease, low volume disease, again, it did not seem to work. You can see there the hazard ratio of 1. So switching gears to abiraterone studies now, we have other drugs, and the biggest answer to the case was abiraterone. So what about the trials in that space? Well, there are two. There's one called Latitude, and again, I showed you that Stampede had an arm for abiraterone. I just put this up here not to have to read through the whole thing, but there were slight differences between the two trials. Latitude had different criteria for admission with regards to bone lesions or Gleason. Stampede also, it depends on if they were newly diagnosed. Again, they had to fulfill definitions of 2 greater than or equal to 2 high-risk features. Some of them relapsed after local therapy. And that is a little different. I think all in your practice know that someone that walks in your door with a PSA of 50 and metastatic disease is probably different from that patient that you've done surgery on or have had radiation therapy and come back to you with a slowly rising PSA and you watch them and they have metastatic disease. They're very different people. So Stampede allowed both of those in. And again, I'll show the Stampede data first, and this is the arm that we're talking about, arm G. Okay, I will get to arm H at a later slide, but arm G, that's the addition of abiraterone right up front, and what do those results show? And again, just kind of cutting to the chase, when you look at specifically for the patients with metastatic disease in that trial, overall survival, again, you can see here, I don't have the exact months, but there was a clear survival advantage at a hazard ratio of 0.61. This is abiraterone with ADT, and the black line is just ADT alone. And of course, failure-free survival is obvious. What about Latitude? This was that same month. Karim Fazazi also had in the New England Journal. This is 2017. The Latitude results, and you can see here they look almost the same. When you look at this was again almost 1,200 patients, and the black line at the top there is abiraterone plus hormonal therapy, ADT alone, and this is ADT alone. So you can see here that there's a clear survival advantage as well as, of course, PSA progression advantage with the addition of abiraterone. Just 2 months ago at GU ASCO in San Francisco, the final analysis, if you will, was presented, and I'm showing these results. It is published in Lancet as an EPUB, showing the final analysis here listed here after 850 events on the trial, so a very long follow-up. And really can have some more robust results. And again, at the bottom line, hazard ratio of 0.66. And when you look at the overall survival advantage of the addition of abiraterone to ADT alone, you can see there that that's almost 20-month survival advantage in these patients, a quite significant advantage. And it actually looks across. This is the forest plot here, showing by all different subgroups. This favors abiraterone plus ADT. This favors ADT alone. You can see here basically in almost every subgroup at a significant level favoring the addition of abiraterone. It also, I think Dr. Penson talked about quality of life. There's no doubt that for our patients it's a very important aspect about pain control, other therapies. And when you look at the final analysis of Latitude, again, the addition of ADT, you look for pain progression. It's a very long, significant difference in pain progression between 16 months and 47 months. So it's well over 2.5 years of advantage of giving abiraterone. And again, when you look at high versus low disease, it does have a signal in both. This is still yet not reached, but the biggest advantage is in high volume, but it has an advantage in both. So what about the new kid on the block? This is the ARCHES. This was, again, just presented 2 months ago at GU ASCO. It's not published yet, but Andy Armstrong gave me permission to present their ARCHES results here in brief. And again, the entire data is now forthcoming. This was an international double-blind trial of enzalutamide plus ADT versus placebo plus ADT. And again, very similar design. Metastatic patients walk in and they're randomized to either what was standard of care, ADT alone, versus the combination of the two. And the primary endpoint was radiographic progression-free survival. You'd probably expect the punchline on this, and I'll get there in a minute, but I just want to show you baseline characteristics because I do think it's important to note that this was the performance status was 0 and almost 80%, so they were really good performance status patients. Most of them had high volume disease, but not all. And then when one looks at other characteristics, there were even some that had previous chemotherapy, okay, and before they entered this trial. Again, cutting to the primary endpoint, the radiographic progression-free survival, when one looks at the combination therapy here in the blue, enzalutamide plus ADT versus the placebo, again, you can see a clear survival advantage. The hazard ratio is 0.39 at a very significant level. This is not even reached yet for this arm, and this was somewhat of an early reporting. When one looks at the forest plot of who does better, or is there a group of patients that appear to do better with the combination therapy, again, this favors the combination of enzalutamide plus ADT. This is ADT alone, and you can see here this is the line of unity. And basically every subgroup, in particular the two ones of interest, are high volume versus low volume, looks the same, at least on this initial analysis, for the primary endpoint of progression-free survival. And then the other one is even in patients that have received prior docetaxel. Again, not many patients, but of those that did receive it, it does also look like there's an advantage. Again, time to PSA progression, not reached yet for median, and that's yet to be reported. Time to initiation of new therapies, again, not reached, but you can just look at that and it will eventually become significant. And of course, the kind of big one that we're all waiting for is overall survival. And overall survival is not the primary endpoint of this trial. However, we're still waiting for the results of this. Are these curves going to separate more later? We kind of expect it to. Look, the follow-up is quite small still, or short still. So we'll have to wait on these results. The last one is the last arm of STAMPEDE that I showed on that trial, arm H, which is the randomization of metastatic patients to ADT alone versus radiation therapy to the primary prostate with ADT. It was a very large study, 2,000 patients, and overall there was no OS survival advantage. The hazard ratio of 0.92. However, when they took that 2,000 patients and they said, let's look at the 800 that had low volume metastases. So 800 that had low volume metastasis, and when you look at just those patients for overall survival, there is a clear benefit to giving radiation therapy to the prostate in the setting of metastatic disease at a hazard ratio of 0.68. You can see here the curves. There's no doubt there appears to be a very nice separation, and especially as this matures, it might even get bigger. So those are the trials that underpin the NCCN guidelines, which I'll spend the last few minutes talking about, as well as future trials. This is the NCCN guidelines that just came out here, this version just a couple months ago. And one looks at, again, the M1 patient, and this is castration naive. This is how they term castration naive or hormone sensitive. It's the same. But in the castration naive setting, these are your options. ADT plus docetaxel, we think that's in high volume disease, right? ADT plus abiraterone, ADT plus EBRT to the primary tumor for low volume, hormonal therapy alone, and as well as this Abby with methylprednisolone. And again, there are all these little footnotes here which I'm going to run through, but before I do that, so this is a younger man that comes in after his younger brother, 50-year-old, had a first PSA and was found to have high-grade prostate cancer, comes into the clinic. He has a little bit of right-sided induration. His PSA is about 11. A prostate biopsy reveals a high-grade disease in all the right-sided biopsies. Staging studies now show higher volume, pelvic lymphadenopathy, multiple rib mets, multiple spine and pelvis mets. He has hypertension, hypercholesterolemia. He's had an appendectomy. And then he has a family history of prostate cancer in his brother, of course, who just got diagnosed. His mother and his aunt had breast cancer. So in your current practice, what would you recommend as the next step? Given the past discussion, Abby plus prednisone with ADT and docetaxel, radiation, surgery, further genetic testing, or uncertain? So kind of equal between Abby and docetaxel standards. Higher volume disease, you can give either, certainly. Further genetic testing, very interesting. I love that. 30% are saying further genetic testing, surgery and radiation. Okay, so next slide. So here are the guidelines which I just showed you. There are some footnotes here, and before I was going to go to the footnotes, I did want to talk about a whole new page on the guidelines, which talks about genetic and molecular biomarker analysis in advanced prostate cancer. Specifically, these are the ones that are metastatic or regional. I mean, this is even high-risk disease, so high-risk early prostate cancer may be node positive. And now the NCCN comes down very firmly. These are actually recommended. You know, I think you see guidelines all the time that say consider, but this is recommended. So recommended for DNA family history of known germline variants, and genetic testing for germline variants should include MLH, MSH, and PMS2 for Lynch syndrome, as well as what we call the HDR or DDR genes, such as BRCA1, 2, ATM, PALB2, and CHEK2. These are cancer predisposition families. They really change therapy. We might be able to get into that in the question and answer, but this is recommended now. There's also a consideration of tumor testing and consideration for not only for in both the regional and metastatic setting. So I'll get to those footnotes now. Remember, this is the guidelines, and this footnote said basically the same thing. It said, look for microsatellite instability in the tumor, consider it. And importantly, it says that if it's found, refer for genetic counseling, and these type of mutations indicate eligibility for IO immunotherapy, immuno-oncolytics later in the line of CRPC, and that's good to know now. The other one is this footnote EE, which is also consider evaluating the tumor for other we call homologous recombination DNA repair, so the DDR mutations such as the BRCA mutations. And again, why do we do that? Because these patients might be eligible for early use of platinum chemotherapy. So it's not taxane, it's platinums, and it may be even PARP inhibitors. So I think that these are new footnotes on the guidelines, very important. And again, I think in the future these will really become to bear, certainly on testing for all of you, but also in your everyday practice. The last footnote there I think is relevant for the conversation of how to choose therapy, which is a footnote saying that ADT alone, on all those options, ADT alone was an option. ADT alone usually is recommended for patients with life expectancy less than 5 years. Okay, so that can be an option. You don't always have to add chemotherapy or abiraterone. So I have 2 slides on some considerations and the practical considerations. And again, these next 2 slides we could spend a whole lecture talking about because this is the art of medicine. But who do you give more therapy? Who do you add docetaxel? Who do you add abiraterone on? Certainly there's volume of disease issues, like as we said, low volume, give abiraterone with ADT. High volume, either chemotherapy or abiraterone. There are some very practical considerations, which again, maybe we get into in the question and answer, but there are issues that surround patient comorbidities. That's an important learning objective of this morning, to understand patient comorbidities and how to monitor those. There are some AE profiles, of course, taxane-based chemotherapy versus more higher level antigen blockade. Duration of therapy, obviously, docetaxel, you get that in pretty quickly and they're done, although abiraterone is a continuous abiraterone for years. Administration issues, of course, infusions. And then there's this issue of payer coverage and so forth. There's really no data to say how to sequence the two, which two to go first, which two to go second. And I think that that's forthcoming, but that's all we can have time for with regards to the sequencing. So I'll close with a couple things, and this is the last slide on AE management. And again, when one looks at the NCCN guidelines, there's a whole page. There's actually 5 pages on the principles of ADT. There's 5 pages on the principle of ADT, and this is just one of them. And there's some highlights that you can read for yourself there that you really have to pay attention to the cardiovascular and metabolic AEs. You can screen for bone health. So screen for osteoporosis, vitamin D and calcium are part of the standard of care. And then, of course, screening and intervention is also recommended, not only for cardiovascular disease, but for the so-called metabolic syndrome or diabetes that you might see with ADT. So again, I'll close the last couple of minutes on ongoing clinical trials, and there are many ongoing clinical trials. Some that will be presented within the next month here in Chicago at ASCO. This is the first one. This is going to be a late-breaking abstract at ASCO. In June, this is the so-called ENZAMET trial. It looks very familiar to the ARCHES trial. This is patients with metastatic disease, and they come in and they give the enzalutamide with an LHRH analog or just the LHRH analog alone. What's the difference in this trial? The major difference is OS. The major difference is that they're really an overall survival endpoint. The other difference is in the ARCHES trial, there were a few patients that didn't have metastatic disease, but this is really only metastatic disease. This is the other one that will be presented again, an abstract at ASCO here in Chicago next month. Very similar design, metastatic disease, but now with the other agent, apalutamide, another anti-androgen. Do we think it's going to be that much different from the enzalutamide trial? We don't think so. Certainly there might be AE differences, but this will be reported. And again, the primary endpoint is OS as well as radiologic PFS. This is a SWOG trial. That's Niraj Agarwal's trial. This is fully accrued. It's called SWOG 1216. And again, newly diagnosed metastatic disease. And this is randomized to TAC 700 plus ADT versus what we call complete blockade with bicalutamide. And then again, primary endpoints OS, fully accrued, looking at the data. Might be another year or so before we report this. And the last one is this trial. Very complex. 4 arms, almost 1,200 patients. And again, you can read it yourself there. This is a prospective trial. Again, ADT alone, standard care, versus abiraterone and prednisone versus local RT. And I think probably the most interesting arm of this trial is the last one. We think that these might be slightly underpowered, but this last one will be very interesting, having radiation therapy in addition to advanced androgen blockade with abiraterone. And again, this is called the PEACE 1 trial, and overall survival is the final endpoint. The last one that's just opened up is called SWOG 1802, and Brian Chapin's the PI of this. Is a very interesting, very important trial. I think one of the most important trials, at least in the U.S., that we're doing currently. And this is testing a very similar concept. If someone has metastatic disease, if we treat the primary site, if we treat the source of the metastatic disease, will that help the patient? And again, this is an interesting trial design where patients with metastatic disease come in and they get what we call best systemic therapy, or dealer's choice standard systemic therapy. So that can be ADT alone, ADT plus hormonal abiraterone, or docetaxel now. I think that's really what's going to be going on for 6 months. And then in the 6 months, they're randomized to either definitive treatment with prostatectomy, mostly prostatectomy, or radiation therapy, or just continuing on standard therapy. The primary endpoint will be overall survival. It'll be a 1,200 patient trial. Again, if those of you in the audience that are involved in clinical trials in the U.S., in the cooperative groups, the NCTN mechanism, a very important trial, and I encourage you to enroll on this trial. So that's all I have. Thank you very much for your attention, and I'm going to turn it over to Dan.
Great talk, Dan. So we're going to be talking about biomarkers in the treatment of advanced prostate cancer. So the treatment of metastatic prostate cancer is evolving. As you saw from the previous talks, we are tending to move our treatments up earlier. If you would have looked at this graph a couple of years ago, you would have seen that there was no indication for giving abiraterone or docetaxel in the hormone-sensitive state. Now we discuss this option with our patients and select treatments based upon risk as well as the comorbidities. But that's leading to a different problem. You're changing the disease biologically. So then down the line, do you give abiraterone after they've received docetaxel? How do you select your agents for first-line therapy? Docetaxel is then administered after other hormones. So is this going to be moved up right at abiraterone failure? And then how do we integrate all of these new agents in the treatment of castrate-resistant prostate cancer? This is a big problem, and we've really not had any biological markers to help us think about this. So the way I like to divide this up is in terms of different classes of drugs or mechanisms. We have immunotherapeutic agents such as sipuleucel T. Pembrolizumab is approved for a very, very small subset of all cancer patients. We'll talk about that approval. Hormonal agents such as abiraterone, enzalutamide, and then docetaxel may have a hormonal mechanism by trafficking or inhibiting the trafficking of the androgen receptor into the cancer cell. We have cabazitaxel, which is really the only sequence-dependent drug. It is approved for those patients who failed docetaxel. And then we have DNA-damaging agents such as radium-223, and perhaps in the future we'll have the PARP inhibitors. I also like to think about the patients in terms of their volumes of disease and the distribution of disease. Are they symptomatic? Do they have bone pain? Or are they asymptomatic? Do they have visceral metastases, or are they bone only? Are they pre-docetaxel or post-docetaxel, and then integrated in the treatment algorithm is the class of treatment? In the future, I think we're going to be looking at biological markers, and we're going to be discussing MSI, ARV7 in this talk, as well as DNA repair. So we know that patients who are castration resistant do retain their androgen receptor, and this is one of the mechanisms. The overexpression of the androgen receptor or the deregulation of it are one of the mechanisms involved in androgen receptor progression of prostate cancer. But there's also intracrine synthesis of androgen. There are a variety of different cofactors that can activate the androgen receptor. And again, these can cause prostate cancer growth, and despite the fact that these patients have castration-resistant disease. But in addition to the androgen receptor, we're now discovering that there are a variety of different markers that are important to castrate-resistant prostate cancer and growth. These include P53, P10, the retinoblastoma gene, which is expressed in about 20% of castrate-resistant prostate cancer specimens. And what's becoming more and more important are the DNA repair genes. The problem is, of course, the obtaining tissue for these patients. We know that about 90% of prostate cancer patients have metastases to bones, so that is somewhat problematic in obtaining a bone biopsy. Do you know that you're hitting the right spot? Is the sclerotic bone that has already responded to the primary antigen blockade? So it's led us to look at different types of ways of obtaining tissue. Clearly, a soft tissue biopsy is an easy way to obtain that, but now we're looking at circulating tumor cells, plasma DNA, as well as what we saw before, different imaging techniques to detect different types of markers such as PSMA. So these will all come into the armamentarium in the future in the treatment of prostate cancer. I'd like to first talk about immune therapy. As we know, there's considerable excitement with immune therapy in kidney cancer as well as bladder cancer, and we know that the PD-1, PD-L1 pathway is important in both of these tumors. We know that cancers can mutate themselves, and these mutations can cause aberrant proteins. These are recognized as being foreign by the immune cells, and the immune cells actually develop a way of evading that surveillance, as I call it, almost like the cloaking device from Star Trek. They're not seen by the immune system, and this is through the PD-1, PD-L1 axis. PD-L1 expression is seen on the tumor cell, as we see also that this ligand PD-1 can dock with that, and that causes the activation of the immune system. So this pathway is inhibited, and we can block this particular pathway and reactivate this by monoclonal antibodies that target the PD-1, PD-L1 axis. So again, it's important to remember that there's different types of expression. There's PD-L1 expression on the immune cell as well as PD-1 expression on the tumor cell, and it's important to differentiate that. Now, there's a lot of controversy about the expression levels of PD-L1 in prostate cancer. It seems that in a very small study, and there's been some question about the methodology, about half of hormone-sensitive radical prostatectomy specimens will express PD-L1, and whether that's actually real or not, I think needs to be confirmed in other studies. But also, there's an upregulation of PD-L1 on the immune cells, the dendritic cells, after patients are treated with enzalutamide. So this is also leading towards the fact that there may be some hormonal regulation of this. But disappointingly, with the first studies that were done with nivolumab, which is a PD-1 inhibitor, showed that there was no demonstration of expression. There was no response, but this was in the pre-enzalutamide, pre-abiraterone era. And more recently, about 15% of specimens that are castrate-resistant were found to have PD-L1 expression. Now, there's another important marker called microsatellite instability. This is a condition of genetic hypermutability that will result in impaired DNA mismatch repair, and this repair will correct errors that occur spontaneously during DNA replication. And the proteins that are involved or that are a product of these mismatches are basically those that can cause neoantigens. And normally you excise them, but then you start, in these patients who have this mismatch repair, you start accumulating small repeats of nucleotides, most often GT or CA, that can actually then cause immunogenicity. And this, again, is something that's seen in a variety of different human tumors. This can include prostate cancer, colorectal cancer, and there is a drug that is approved by the FDA. It's the only pan drug approved for different tumor types, and that's pembrolizumab. Now, what's the data in prostate cancer? This is a recent publication from Sloan Kettering that looked at 1,033 specimens of prostate cancer, and they looked for mismatch repair. It's expressed at a low rate, 3.1%. 2.2 had high mismatch repair, and 9 more had indeterminate scores. And when you look at these particular mutations, you see that 21% had a pathologic germline mutation in a Lynch syndrome-associated gene. Now, this actually can occur evolve over time. There were 6 patients who had more than one tumor analyzed, and 2 of those patients developed mismatch repair over time. So what about treatment? This is the data from that analysis looking at pembrolizumab. About half of those patients who had the mismatch repair had objective responses. Same thing with PSA declines. So this, again, is marking for a patient who potentially can respond to immune therapy. I mentioned before that there are other tumors as well that are approved by the FDA, 86 patients in the original trial. It's predominantly seen in colorectal cancer, and there was one patient with prostate cancer who had a complete response on the study. Other markers important to the response to immune therapy, one is CDK12. This also is involved in DNA repair and basically excising gene fusions as well as tandem repeats. And again, as I said before, these particular patients can tend to have neoantigens present. And this is from a Arul Shanayan's group. This is again with pembrolizumab. We see this patient who had a CDK12 mutation had infiltration of T cells into their tumor specimens, as well as objective responses in soft tissue. Pembrolizumab also may be active in patients who have BRCA mutations. This is from data from Johann de Bono. He looked at 5 different cohorts of patients with castrate-resistant prostate cancer, treated these patients with pembrolizumab. These were patients who either had measurable disease, PD-L1 status, and also they were pre- and post-enzalutamide. What Johann found was that the response rate was modest. 11% of patients had a PSA decline. When you start looking at the different objective responses in the cohorts, it was actually, again, very, very modest, about 5% having an objective response rate. But you can actually enrich your patients by looking at BRCA1 or BRCA2. Objective response rate goes up to about 11%. For those who are negative, it's 3%. So again, this may be a way of sorting patients out in terms of immune therapy. We've talked a lot about abiraterone. We know this is an androgen biosynthesis inhibitor. This is our second pathway that we potentially can use markers in. And we know that this drug is important in the conversion of DHEA to androstenedione and then subsequent to testosterone, and it helps to alleviate or at least reduce testosterone production in those cells that may make it in a autocrine manner. 2 randomized trials have evaluated abiraterone combined with prednisone. One, of course, the Cougar 301 trial, which led to its first approval, is in patients who had received prior docetaxel. And as we know, there was about a 4-month improvement in the median survival and a 34% reduction in the risk of death. And this was independent of the amount of prior chemotherapy that the patients received. Same thing with Cougar 201. There was an improved survival in the pre-chemotherapy patients in favor of abiraterone and prednisone compared to prednisone alone, with a hazard ratio of 0.81. Enzalutamide is also a hormonal agent. As we know, it has a different mechanism of action. It basically inhibits the signaling of the androgen receptor on a 3-fold level. It will inhibit the binding, inhibit nuclear translocation, and also the interaction with DNA. There is no agonist effect seen with enzalutamide. And you can basically draw these curves on top of each other in terms of ABI or ENZA. We see that there's about a 5-month improvement in median survival in the post-chemotherapy patients, and again, a 30% reduction in the risk of death in favor of enzalutamide in terms of the pre-chemotherapy patients. So the question is, what do you do if a patient fails abiraterone? Then they're asymptomatic. You don't want to give them chemotherapy in that situation because of the fact that you may be giving them more symptoms by chemotherapy. Do you give a second anti-androgen after ABI or vice versa after enzalutamide? So this has actually been fairly disappointing. The PSA responses to these agents after the prior agent are generally about 10 to 20%, and the radiographic progression-free survival is generally short. It's about 3 to 4 months. And these tend to be less effective after taxanes, and taxanes seem to be less effective after ABI and ENZA. And this is a summary of the retrospective data that's been generated. The only one that's really prospective is de Bono's, which is post hoc. But again, as we see here, there's a short duration of response, and the survivals range from about 9 months to about 12 months. Not particularly impressive. And the question is, how can we select out those patients who are the good actors in this particular situation? We have to think about the resistance mechanisms, and we know that there are multiple resistance mechanisms to these drugs because they target different areas. And the common theme between the two is the fact that both are affected by splice variants. Abiraterone also tends to be affected by those particular steroid synthetic pathways, and enzalutamide may be also affected by GR expression. So again, there may be slightly different pathways, but the one common denominator is ARV7. What is ARV7? This is basically a truncated version of the androgen receptor. The androgen receptor has 3 different domains. One is the ligand binding domain, the second is the hinge region, and the third is the DNA binding domain. So when you basically chop out the ligand binding domain, as we see in these splice variants, it can constitutively activate the androgen receptor, and you don't need androgen to activate it. So that's the reason why this is a resistance mechanism. So the work out of Hopkins by Dr. Antarakis demonstrated that this was an important factor towards resistance in patients who were treated with abiraterone or enzalutamide. As we see from these progression-free and overall survival curves on the right, in the negative patients, those patients have a overall better survival, a PFS, than those patients who are positive. And then the same thing with the overall survival. And these are patients who are treated with Abi after Enza or Enza after Abi. Now, there are some patients who are positive who respond, and patients who are negative who progress. So that's again showing you that this particular mechanism of resistance is multifactorial and again may be drug dependent. Now the interesting thing is that you do tend to see better responses with taxanes than you would with a second generation agent in those ARV7 positive patients, but the overall response rate with taxanes seems to be a little bit lower than what you would see with the overall population of patients that may have not received Abi or Enza, but nonetheless taxanes seem to do better in the ARV7 positive patients. So the interpretation of these particular curves is the fact that if you're detecting CTCs that have ARV7, it's demonstrating they have a primary resistance to abiraterone and enzalutamide. You still retain some sensitivity to taxanes. They may be more efficacious than other AR-directed therapies. In the negative patients, taxanes probably have similar efficacy to the AR-directed agents, and then we potentially can use this as a way of selecting treatment of taxanes versus AR-directed therapy. A recent trial called Prophecy, which was led by Andy Armstrong, basically looked at patients who were castrate resistant, and they were checked for ARV7. They received Abi or Enza, and then they went on to receive taxane therapy, and they were treated until progression. And what we see here again is a very, very similar pattern. These are 2 different assays, one from Johns Hopkins. The EPIC assay looked at the nuclear expression of ARV7, and those patients, when we look at survival, the ARV7s overall had a better survival, the negatives versus the positives. And then again, if we look at PSA changes from baseline in those patients we treated with Abi or Enza, we see again the same pattern that we saw before. There are patients who are positive and negative who do respond, but the majority of those patients who are ARV negative respond. The positives tend to progress after treatment. Now the interesting thing again is the fact that the ARV7 marker is a positive marker for overall survival, or prognostic marker. And I think this is an important part about this particular assay because there was a trial that was done a number of years ago trying to select out ARV7 positive patients. It's a drug called glitaterone. And this was supposedly active in ARV7 positive patients, and they were looking for patients who were asymptomatic, not on pain medications, in terms of receiving this particular treatment. And they really couldn't find patients. In fact, they often progressed rapidly. And this is another factor about ARV7. It's marking for rapid progression of disease. And again, in terms of prediction, it's a good marker. But the question is, again, you're looking at patients who are actually tending to do more poorly overall. So what about our third, DNA repair? This is, I think, really a fairly hot topic in castrate-resistant prostate cancer. There are a number of clinical trials, which we'll be talking about in a few moments. But this is actually a much more common event than we thought in the past in prostate cancer. In patients who are castrate-resistant, 1 in 10 patients have a germline DNA repair mutation, and this is predominantly BRCA2, 44%, ATM, CHEK2, and BRCA1 to a lesser extent. And then there are a variety of different other DNA repair mutations that are involved. And not all men with a germline mutation have a family history of cancer. And that's actually, I think, an important part in our history taking. So if we start looking at other cancers, we see that there's an increased risk of other cancers in BRCA carriers. Prostate cancer, the average man without a mutation, it's 16. BRCA mutations is 15 to 25 relative risk. We also see that melanomas, breast cancers are also involved as well. So you have to also talk to the family about what their mutation status is and whether they should be checked or not. And then finally, I think the other important thing about BRCA2 is that it marks for a poorer outcome in those patients who have localized disease. As we see from this blue curve, if you're BRCA negative, you tend to do better than those patients who are BRCA positive. And again, this may be an important prognostic factor. So how do we use this as a therapeutic target? Well, we look at something called a PARP inhibitor. And these are drugs that have approval in breast cancer as well as in ovarian cancer. And they're involved in multiple different factors of DNA regulation. They're involved in DNA repair. They're involved in transcriptional regulation, modification of chromatin. They're involved in mitosis or regulating mitosis. And then finally, they're involved in cell death. So this is the concept of synthetic lethality that's used in breast cancer as well as in ovarian cancer, now to prostate cancer. So there are two different ways that DNA can be damaged. One's a double-stranded break, and the second is a single-stranded break. The double-stranded break is repaired by basically the BRCA pathway, but single-stranded breaks are repaired by PARP inhibitors. So if you knock both of these out, you can cause cell death. And that's what's called synthetic lethality. So olaparib is a PARP inhibitor that's approved for breast cancer and ovarian cancer. And Johann de Bono went forth with something called the TOPARP study. In men with castrate-resistant disease, these were docetaxel pretreated. Overall, the response rate was about 33% in all patients or all comers. A post hoc analysis found that 16 patients had mutations in DNA repair. That's about a third. That's maybe a little bit more than what we normally would expect. 67% had none of these mutations, but 14 of the 16 patients with the DNA repair mutations responded. These, again, were predominantly BRCA2, and then only 2 patients of the 33 responded in the who were BRCA negative initially. And you wonder whether these particular biopsies were representative of what was going on, whether they developed a somatic mutation later on. Rucaparib is another PARP inhibitor that's approved for ovarian cancer. This data was presented at ESMO last year. It's a large phase 2 trial, 85 patients. Rucaparib was given at 600 milligrams twice a day. And as we see here again, predominantly BRCA2 mutations, some ATMs, some CDK12s. And the efficacy populations were PSA responses and radiographic responses. Again, clinical characteristics, median PSA is in the 50s, predominantly high Gleason scores at initial diagnosis. Now, interestingly, it does seem that there's a higher proportion of African Americans on this trial, and this may represent the prevalence of DNA repair mutations. Is there something biologically different about these populations? We know that, interestingly, that patients who are treated with docetaxel-based chemotherapy, if they're African American, they do better than the general population. So when it's adjusted for risk factors, so there may be something about the genetic modifications that go on with this particular disease state. But as we see here, there's about a 44% objective response rate, predominantly in those patients who are BRCA1 and BRCA2. If you look at ATM, they don't quite make the criteria for partial responses. Same with CDK12. You see some tumor shrinkage, but not enough to see a PR in this particular situation. So that's actually, I think, an interesting observation. This is predominantly BRCA1, BRCA2. BRP1, also another DNA repair, did have a significant response. And the PSA decline rate is about 50%. These are not the only 2 PARP inhibitors that are out there. There are other ones, talazoparib, niraparib. These are all being evaluated in prostate cancer with the intent of registration in both the hormone refractory, and some are now being looked at in the hormone sensitive situation. And I think that that's going to be very, very interesting. The question is, can you basically knock off androgen blockade in these particular patients if they got a PARP mutation? And again, that's not standard of care. That's something that's investigational, and clearly we think we need to look at these in the future. So in conclusion, ARV7 is a promising biomarker for sensitivity to enzalutamide and abiraterone. PARP inhibition is a promising therapeutic target in patients with BRCA mutations. All patients should be considered for MSI testing. It's in the guidelines that you should consider it. It's not an absolute, but in my opinion, I think that the response rate's high enough to justify looking for this particular marker. And again, this would select for those patients who may be eligible to receive pembrolizumab. So I'll stop there, and I'd like to call up my two colleagues to the podium so we can take questions and answer any thoughts that you have. And I've got some from the iPad we can talk about. So let's go to the first question. What are you doing for patients with M0 progressing on ADT, APA, or enzalutamide combinations, and what about metastatic hormone-sensitive prostate cancer after combinations?
Well, so for patients M0 and they're progressing on Enza or on APA, right now we really don't have any other FDA-approved agents. You have to assume, and there's no good data on this, but since APA and Enza, and when it comes along darolutamide are all sort of related drugs, that if you fail one, you're going to fail another. So there's really I don't think there's going to be any advantage to, if someone fails on, say, APA, to then try them on Enza. The problem is if they're still M0, you don't have any other FDA-approved agents. So at that point, I think you're observing them until they become M1. Yeah. You could make the argument that maybe there's a role for AbbVie as an example, or early dose of Taxol, but it's certainly not indicated. That would be off-label use. I don't know if you have anything to add to that.
I mean, what do you, with regards to sequencing in general, the easy question is, starting with, in any state really, starting with APA, basically Enza versus APA, either one. What is your perspective on the sequence of the two? What we hear, I think what urologists at least hear is, you're starting with apalutamide, going to Enza might have a pretty decent signal, but the opposite might not. I mean,
it's, I think all of the evidence right now is anecdotal at this point, and I think it's based upon experience. We've sequenced a couple of patients and not really seen anything with the second drug. I think that the biggest structural difference in the drugs is darolutamide versus the other two. So whether that's going to show anything or not, again, we have to really do prospective trials to see in our patients whether there is a difference or not. I don't know at this point. But certainly I think it's reasonable to consider sequencing them. We're also looking at clinical trials. Don't forget that these patients may actually benefit from going on a clinical trial in terms of things that are out there. We're looking at some novel vaccines in that particular spot. So again, I think we should always push our patients to clinical trials in that particular setting.
Questions out there? The question was regarding dose reduction due to side effects, particularly in this case fatigue, right? And you're particularly talking about which agent? Any of them? Okay. All right.
Well, I like giving these drugs at nighttime. I mean, I often will tell people take enzalutamide before, although it's recommended to take it during the day. The majority of fatigue then occurs at night. I often titrate them, so I may try to, if somebody's frail and they have multiple medical problems, I may start them at half dose and then sort of inch my way up a little bit. So, I think that you have to adjust it for the individual patient. The question about using other stimulants like Ritalin, it's never really been properly addressed. I think it needs to be addressed about giving other medications to try to overcome the fatigue. But again, there's really nothing pharmacologically you can do except to titrate the dose and to maybe change the schedule.
It's all anecdotal at this point. There's no evidence, but like Dan, I see these. I don't actually titrate them up, but I have dose reduced. As you know, and we have, I think, more experience with Enza over the years than APA, it can have a profound effect on their fatigue, on their energy levels. It can have a profound effect on their personalities at times. And those patients, it's worth a try dose reducing. Sometimes even dose reduction doesn't work and you have to switch to a different agent.
The other thing that I've really been pushing at the initiation of androgen blockade, as well as the new novel agents, is making sure that these patients stay physically active. Exercise. That helps a lot with depression. It helps a lot with fatigue. It's cheap, except for maybe if you hire a trainer. But again, these patients lose muscle mass over time, and it leads to falls and it leads to other things. And so the more we're proactive in healthy lifestyle, making sure that they exercise, making sure that they eat properly. Weight gain's a big deal here as well. Keeping the carbs in their diet low, I think that's also something that comes into the overall general management of these patients.
Question down there.
Yeah.
Thank you. Do you have any thoughts or insight regarding enzalutamide and Zytiga failures for people who are maybe considering the phase 1 trial that's out for ARV-110 and that mechanism for people who already have an androgen blockade failure, but now this one would be targeting it in another way?
So are we talking about the Arvinus drug?
Yeah.
Okay, so I have to put the disclosures up that I'm at Yale University. Yale has a significant financial interest in Arvinus. I have absolutely none. But I think it's a very, very interesting thought. So this is a different mechanism of action as opposed to the other anti-androgens. So what this drug does is it ubiquitinates the androgen receptor and obliterates it. So it's another way of getting rid of the androgen receptor, and it's now in phase 1 studies. We can't comment yet on whether it's active or not. We don't know, but we're moving forward, and we're hoping to put our first patient on after May 22nd. Excuse me? Good question. It does not require the receptor. We're not pre-screening people to see if they've got the androgen receptor or not. We're looking at CTCs and a variety of other different things. But we would think that it does because these are PSA, patients with PSA, high PSA levels or overexpression of PSA. And we know that PSA is an androgen-dependent gene, so I would think that it's there. But, the biology of this is going to be very, very exciting to find out how this drug works, if it does have activity, and then moving forward, where do we use it?
My impression on to get to more of that question, and you note that the guidelines do not have anything about AR variants. So, and specifically there's reasons why, because I think that the AR variant, not only testing, but the result of AR variant testing is somewhat controversial. I mean, we present the waterfall plots from Emmanuel and from Johan de Bono and others showing pretty good signal with regards to AR variant and choice of therapy, so forth. But as far as on a prospective level and where that's going, I still think it's somewhat controversial. I know that on an industry level there are some ties with various different assays. But when you look at it now, currently it is not standard of care. It's not recommended. It's nowhere on the guidelines. Will it eventually be? I hope so. I hope we have the age of personalized, more precision medicine, but at this point, it's up in the air. So.
Okay. If no other questions, I'm going to move on to some of the iPad questions. What biomarker testing do you think should be standard of care now, David?
In what setting?
Well, let's talk about the hormone. Let's talk about the newly diagnosed state first.
So, we had a meeting here at the AUA last year when it was in San Francisco talking about the role of genomic tests, not genetic tests. That's a whole other animal, which I'll probably defer to Dr. Lynn to my right. He's smarter than I am. But with genomic testing, it's interesting. The real test in my mind in the newly diagnosed patient, low-risk patient who you're trying to decide between active surveillance and aggressive therapy, how much more do these genomic tests add to what we already know? So the 3 tests in that space, which I think are widely available, Prolaris, the Oncotype DX, and the Decipher test, do they really add that much more to the clinical information we already have in terms of Gleason score, number of cores involved, PSA, et cetera, so forth? And if you look at all these tests, Dan, what they do is they're all nomograms.
Yeah.
So all that stuff already adds in. What's the standard of care? I don't think there is a true standard of care at this point. I think a lot of people are ordering these tests. What I always sort of tell people is I'm only going to order the test if it's really going to change what I do. If someone has a single core of Gleason 6 disease, it's really unlikely to change my management. Conversely, if someone has 3 plus Oracle 7 disease, and let's say the 4 is 10%, that's someone who, on the surface, I'm leaning towards saying, look, you probably need to do something, but if we get a genomic test that then moves them down into a lower risk category, they're going to feel a lot more comfortable with active surveillance against change my management. As far as which one goes, each one has pros and cons. The data on all of them have some warts on it, but they definitely do predict post-operative pathology, if nothing else. And I'll defer to Dan.
I would only add that, I totally agree with everything. If you have someone with a microfocal tiny little Gleason 6 disease, PSA less than 10, there's no reason to get, I don't think, to get more molecular testing. So all these tests are prognostic. In other words, they can predict how a patient might do. There's one that's really being marketed as a predictive test. In other words, predicting if they should get radiation therapy and how they respond to that, and that's Decipher. And so that's in the post-op setting that has been shown pretty well now. And then there are other signatures with Decipher to show that it's not only prognostic of how they're going to do, but also predictive of how they will respond to radiation therapy. And there's actually a signature that they're working on now that's predictive in how they will respond to ADT. So it's not only prognostic, but predictive, and I think that is pretty powerful. I agree that we need more clinical data and tools.
So let me just add or ask a question then. Yeah. So, Todd's doing his study.
Yeah.
In the meantime, some of these later adjuvant versus early salvage studies come out,
yeah.
and they will end up showing that there's no, I'm not saying this is going to happen because I don't want to offend any radiation oncologists in the room, but let's say those studies showed there's no difference between adjuvant versus early salvage. Yeah. At that point, is there a role for genomic testing?
Yeah, I think so. Yeah. I know that on a retrospective basis, they can look at the tissue from there. There are probably subgroups in there that work.
You're right.
There probably are, and I don't know they'll be powered well enough to do that, but I'm hopeful that it can add to the clinical data. But right now, when we have in my group, the PASS active surveillance group, we've looked at all the models, and there's PSA density, number of cores, PSA, and so forth. And then when you have a model of that and you add on top a genomic marker, and we're publishing this soon with looking at the genomic health marker, it really didn't add that much for upgrading.
Yeah.
Yeah, in our practice in castrate-resistant disease, we draw the markers on everybody, and we have an in-house Oncomine panel that we use. We also look for MSI. As I mentioned before, when you find it, you can see a pretty dramatic response. I can think of one individual that we treated for about a year and a half with pembrolizumab. He did extremely well, and he eventually progressed, but we got him a year and a half after he was refractory to docetaxel, cabazitaxel, everything else we could have thrown at this particular gentleman.
So let me ask you and for the audience as well, how do you handle genetic counseling?
That's just what I was going to ask.
Yeah, I mean, do you keep that? And again, it's a really important thing because many of the we're saying, it's color. DNA test, and they have some online. But do you do that in-house, or do you refer them out?
We send somebody to a genetic counselor within our institution. We have a specific person who handles that.
So what do you do? I mean, it's clear in patients with metastatic disease and castrate-resistant disease that's probably useful. In the patient with localized disease, who are the patients you do genetic counseling on? Because this, to me, is one of the big questions now as this field evolves. Or do you?
Certainly the patient who's young, who develops metastases early. We had a gentleman who was 52 years old, had a radical prostatectomy. We picked up a BRCA in him, and it turns out that one of his relatives turned out to have had a BRCA-related breast cancer as well. So it's not only the patient, it's the whole family that you're looking at.
That's
and I think the NCCN probably just recently adjusted their guidelines to basically say that you should consider testing in all patients because you can't predict who's going to get it.
Yeah. I think that one of the take-homes is that, I took a family history, but that I ask about breast and ovarian cancer not as much in the past years, but now I do on all my patients that I see with newly diagnosed prostate cancer, is just to understand whether there looks and smells like there's a signature for hereditary breast and ovarian cancer, because that will have great effects on the patient himself, but also their family members. And many of you in the community, I know at our shop, and I'm sure at your shop, you have a sort of a survivorship clinic or a affected relative clinic to do the genetic screening for the entire family, because it does make quite a bit of difference.
Okay, so let's see what else we have here. I'm just going to go in order. PROSPER included patients with lymph nodes less than 1.5 centimeters below the aortic bifurcation. Is this too small to be considered a lymph node positive disease?
What was the question?
So basically, there are patients in PROSPER who had lymph nodes that were less than 1.5 centimeters below the aortic bifurcation. Is this too small to be considered lymph node positive disease?
That was not considered lymph node positive disease.
Good. And then can you comment on the clinical relevance of lack of seizures, falls, fractures, cognitive impairment in the Aramis in this population? Let's see, please note. So what about the differences in the side effects with these particular drugs?
Dan? I mean, I think the data are the data. They're different drugs, and they have different side effect profiles. I'm intrigued by the signal in coronary artery disease, both in Aramis and in Prosper, just because we have so much data on ENZA in particular, and this is new. Conversely, you didn't see seizures in Prosper with ENZA, so I don't know. I don't know. I think you have to accept the side effect profiles as they're presented in the papers, and counsel patients appropriately. I don't think there's much else to add to that.
Yeah, I mean, what will be interesting is what you, Dan, alluded to, which was the structural difference of darolutamide will be interesting. I mean, if you see, when you all see the structures, like back in medical school, of the ring structure, it's very different from enzalutamide and apalutamide, and so how that affects crossing the CNS and other things will be interesting as it plays out.
Absolutely. One very interesting question I'd like to end up on. So these drugs, we're giving these drugs for longer periods of time earlier in the course of disease. Any difference in monitoring bone health in these men who are on more extensive androgen suppression? Do we change our way that we monitor with DEXA scans? Do we think about different ways of giving medications such as calcium and vitamin D?
See, I didn't think that's where you were going with that question. I thought you were going to talk about cardio-oncology. Which actually we now, with these all these patients on hormones, we have a very large cardio-oncology clinic at Vanderbilt because these patients do have cardiac issues, and as we use more PARPs and immuno-oncologic agents, it's becoming a bigger issue. As far as bone health goes, I think we have to be aware of it, and I think we have to, these patients are on these drugs for a longer period of time. Urologists, I think, have been slow to take up the mantle of bone health, and I think we have to, because we are making our patients osteoporotic, and they're at risk for skeletal-related events because of it.
Well, you're actually bringing up a great point about cardio-oncology, because there's been this shift of putting everybody on abiraterone early rather than going with docetaxel. And then this presentation from Jefferson where there was a 24% rate of death within the first 6 months in patients who have pre-existing issues such as CHF or myocardial infarction. That's something we have to really think about, and we still don't have any good guidelines as to how to manage these patients from a cardiovascular, and it's going to become more and more important over time. Terrific. We're right at our time, so I'd like to thank our great presentations from Dr. Lin and Dr. Penson, and I'd like to thank the audience for their excellent questions as well. So enjoy the rest of your meeting.
Thank you.
Make it.